Everyone for joining again. If you are a continuous attendee to our monthly webinar meetings, for everyone that is new, we appreciate you attending for the first time. We hope you find this content helpful, useful. We know you guys are working and busy, and so we appreciate the 30 minutes, and it is 30 minutes. Anthony will go through slides. I will add comic relief or do some ranting. That's probably not appropriate, but it's at least entertaining. And we will do a Q&A after. So if you have any questions, please jump down to the bottom of the screen for the Q&A, put your questions, and we'll address each of those when this is over. Again, thanks for joining. We've gotten quite a large following now, and we hope the content is useful. I know this is a very big deal. Obviously, we all want to sustain 340B, and so look forward to Anthony unpacking this and giving us the details on what this means for you all. I'll turn over to the great Anthony Velasquez.
All right, Justin, thank you so much. I'm so excited about this because I think several months ago, I felt like all we were doing was giving bad news, right? It was manufacturer restriction on top of manufacturer restriction and entities being really hurt by the financial impact of all of that. But I told you several months ago that I was very optimistic about the future, that I believed very deeply that the 340B program is a safety net program in the United States, and it is critical to the entire healthcare system. And what we've seen recently, I mean, the news is coming out so fast that by the time I prepared this content, there had been like a new bill introduced in Congress, the 340B Patients Act. There had been an appeals that was won by the state of a win in the state of Arkansas that basically said that states could in fact pass laws that would prevent manufacturers from restricting pricing in that state. So there's just a lot of things that are moving right now. A lot of different conversations at a federal level that I think is really important for you all as 340B professionals and us that are in this space to be aware of and understand it to an extent and some of the details that are going on. So I'm really excited to share this content with you all. Just a quick background on me. I've been in the 340B space for over a decade, started my career at an FQHC. Then I worked at several hospitals in the Northeast area, in the Philadelphia area. And I have been at PharmaForce on the third-party administrator side for the last 6 years. So I have that perspective of the entities. I'm still, I still have my entity days at heart, but I'm also working on the technology side and helping you all as covered entities manage your 340B program. So that's a little bit about me, but let's get started right in the content because I'm very excited about sharing details on this bill. All right, so rule number one that I always share when we do this every single month is nothing in this presentation should be constituted as legal advice, okay? This is for educational purposes only. This is for you to know what's going on, and hopefully we're adding value to you as a professional by way of sharing this information. But please consult with your legal team. Please consult with your compliance team if you are thinking of making any changes to your 340B program. All right, now, here's the agenda for today. Here's what we're going to unpack. So we're going to talk about the Sustained 340B Act. Is this bill that's being led in Congress by a group of senators, 6 senators. We're going to talk about the backstory on that, talk about an overview of what is included in the bill, what is the compliance aspect of the bill, some of my pros and cons, just some of my thoughts on the bill, just because I'm in this and reading about all this information on a regular basis. So I want to talk about that. And then I also want to encourage you to participate and give some feedback. There's still time for entities and providers to comment on the bill. So I want to give some instructions on that and some call to actions there. So let's go ahead and get started. So what is the Sustained 340B Act, right? This is different than the 340B Patients Act. So the 340B Patients Act was the federal bill that was just introduced in the House by Representative Doris Matsui of California. If you remember, I shared back, I want to say it was last year, right before the 340B conference, that there was expectation that this bill will be introduced in the summer of 2023. It was not, but it has been introduced now. So that is really good news. Really, really, really good news that a 340B bill has so much interest in Congress that it's actually been introduced. Whether it passes, it's a whole nother story. But we'll take the win, right? We'll take the win. The Sustain 340B Act. The backstory of this is a bipartisan group of senators. They call themselves the Gang of Six, led by Senator John Thune, which is a very influential senator in the Senate. There are some rumors that Senator John Thune might actually be the ranking member of the Senate once Senator Mitch McConnell retires, and also Senator Tammy Baldwin, a Democrat, a high-ranking Democrat on the Senate Help Committee, which oversees the 340B program. They are sort of the ones that are leading this effort and sponsoring this bill. They spent a 6-month-long review of understanding the 340B program. As you all know, working in 340B, it's very difficult for us that work in it day in, day out. If you are a senator or a group of folks in the House or lobbyists that are trying to get into the details of the 340B program, that can take time and it can be very complicated. So there's been tons of meetings with different stakeholders. There was a time where they asked for comments on the 340B program and different things like that. So all of that has now led up to this 51-page draft bill that has been released. And it's been released for two reasons. One, to kind of, get a feel, to put it out there of what they've, put in writing so far. But number two, because they also want more information. There's a request for information that's due April 1st, 2024. If you are a provider and this is not on your radar, I know there's not a lot of time left, but I would highly encourage you to comment on this bill. There are key areas of the bill that have not been filled in just yet that could be very important. So I'll talk about that later in the presentation. But I think it's really important for providers to participate in commenting on this bill. So that's sort of the backstory of where this draft bill came from. There's some very powerful people behind this bill, which I think it's good news for 340B providers. Again, whether it gets introduced or even passed is a whole nother story. But the positive news is that this bill overall is very pro 340B. There are some concerning things about the bill, and I'll get into the details of that. But overall, the bill is very much in support of the intent of the 340B program, as those of us that work in the 340B space know it. So, Justin, I'll stop there and see if you have any thoughts on that. I think everyone is very positive about the bill, but very concerned. I don't know if you've heard anything different related to this particular piece of legislation.
No, but I agree with everything that you said. But the biggest thing is reaching out. Yeah, absolutely go and make comments, but I'll reach out to your own senators in your states. Write them letters. It's easy. It's online. You can find it very easily, and communicate with them and put this on their radar. Keep it on their radar. Obviously, they'll pass it on to their aides, and those are the ones that they're experts anyway. So that's the best thing to do. Keep it in front of your senators and your representatives as well, because obviously it's coming to them eventually, hopefully.
Yeah. So let's get into the details of it. So what are some of the key things in this bill? So number one that I think is important to highlight, and everything that I've seen people have been highlighting this, is that it actually provides clarity in statute of what was Congress's intent for the 340B program. What do I mean by that? Manufacturers and different people that advocate against the 340B program have said that the intent of the program was to only help the uninsured, that It is a program for uninsured people. It is a program that should in some cases, some have made the argument that it should be limited to cash or uninsured patients altogether. This bill does not say that at all. It does not say that the program is limited to uninsured patients, but it further clarifies that it is to stretch scarce federal resources to help safety net providers maintain and expand access. So I think that's a huge win, right? Is that there's no indication on this bill of trying to limit 340B, the reach of 340B, the way that providers use the 340B savings to maintain and expand access. For many of 340B providers, the 340B program keeps their doors open, right? And those of us that are in this space, we know that. We know that that's how it works. On the ground, day to day, the 340B savings are helping safety net providers, rural health providers, clinics, hospitals alike to maintain operations and be able to serve patients and expand services. Okay, so that's number one, huge win, huge win. Number two is, as it relates to contract pharmacy, it reverses or undoes the manufacturer restrictions. It removes limits on the number of contract pharmacies. It doesn't hint at, you can only have a certain number of contract pharmacies, though I have had the opportunity to speak to some people that are very close to lobbyists that are working on this bill, as it relates to the National Clearinghouse. And I'll get to that in a second because I have some really good information that I was able to gather. But basically, there is still talks that there could be some changes to this, and that manufacturer actually do want to add further language here that limits the number of contract pharmacies. There is that rumor going on from folks that I've spoken to that are close to the lobbyists that are working with the senators on this bill. So, but in this draft, there is no such limit. It does require 340B prices for outpatient drugs to be provided at contract pharmacies. It does not limit it to in-house pharmacies. It does not include any of the language that we have seen in some of the manufacturer letters. The bill seems to indicate there's an annual contract pharmacy registration. I don't know what that looks like from an operational perspective, but if I'm interpreting it as it's written, if it's changing the ability of an entity to register a pharmacy from every quarter as it is today to annually, I think that's very concerning. And I would personally like more clarity on what that looks like from an operational perspective. And it does create penalties for manufacturers as well. So those are all, I would say, good things or positive things in the bill. All right, now moving on to a couple more things, and some of these are a little bit more concerning. The patient definition. The patient definition is left blank in this draft bill. The senators have written a letter asking specifically for information from providers on the patient definition. As you all know, at the end of 2023, the Genesis decision came out. There is a lot of speculation that there's a lot of entities considering expanding their patient definition because of that. There's a lot of talks with pharma, thinking that, as I mentioned earlier, the 340B program that should be only go to uninsured patients or cash patients, right? So there's a lot of things that I'm sure the senators are hearing from multiple sides as it relates to the patient definition. So the fact that it's left blank in the draft bill is a bit concerning, in my opinion, and highly recommend providers that are on this webinar to participate in giving that feedback as part of the RFI process, because this could be one section that if it is somehow includes language that's highly restrictive, it could be harmful towards providers, 340B providers. So this is one area that's concerning to me in terms of what's in the language.
Anthony, I would see it as them trying to find a sweet spot between the Genesis decision and what was always historically in the bill as far, or in the statute for patient definition, even to the point of hey, we'll leave it the same as it was, but Genesis doesn't apply, something like that, some kind of
Yeah,
negotiation.
I think so. I think I hope so. I hope so. I hope that that's the case. But again, there's I'm sure there's a lot of voices, you know, sharing opinions with senators and with people that are writing this bill. So, you know, I just think it's an area to closely monitor, if you will. The child site eligibility is another one that was interesting. That there seems to be a disconnect, I think, in understanding child sites. There was very specific language about the child site being 100% owned by the covered entity that seemed to indicate to me that I don't think the people writing this bill really understood how a child site operates, and that it is owned and operated by the covered entity, and all of those things. There was language to extend financial assistance at the child sites, you know, things like that we know in practice are already happening, and all of that. So that was interesting, but nothing, I would say, nothing alarming there. um the one big part of the bill that I think it is alarming is the amount of reporting that it seems like this bill has and is requiring. From requiring of reporting on a regular basis, and I think I want to say it's annually, but reporting a bunch of different things related to your 340B program, such as how many individuals were dispensed or received 340B drugs, the cost incurred at each site, charity care at each site, discount realized, the use of savings. I mean, like there was a significant number of reporting metrics that entities would be required. And it seemed like it was beyond some of the states that have passed state level reporting, but this was like a federal level reporting that even seemed to indicate it will be made public. So there's some concerning stuff here related to the reporting. I don't think in general providers are opposed to reporting, but it does create a burden for providers to, you know, report this information, gather this information, you know, present the information. So this is yet to be determined, and I'm curious to see if this stays in the final bill or if it gets dropped.
But Anthony, if you're an FQHC on this call, you're looking at that saying, well, that's the UDS report for, as a grantee. And so, yes, it is burdensome, but FQHCs do this every year in February. I mean, it's the UDS and their whole entire program. This is obviously singling out the 340B, but it looks like HRSA, being that they, taking the UDS data, they would be able to recommend something similar and have that kind of portal that you would, and make it public, those types of things. So it's just my opinion on that piece.
Yeah. Yeah. Again, I think that the manufacturer restriction is the big one, right? I think that there are things here that are a compromise, and this is just my opinion. Anthony Velasquez's opinion, not PharmaForce, but my opinion is that there's things here that are good, and there's things here that are concerning. All right, now let's talk about this compliance piece. There's another part. There's other parts of this bill that are very interesting, and this goes to what I was just sharing. I got some insight from some folks that are very close to lobbyists that are working with the folks that are writing this bill. And what I heard was the duplicate discounts and the National Clearinghouse is a piece of it's a piece of legislation in this bill that is of the most interest to manufacturers. So here's what's going on here. The manufacturers are concerned that there is a significant amount of duplicate discounts, not on the Medicaid side as we will understand it in the 340B world, but that there is a significant amount of duplicate discounts on the commercial side, where the manufacturer is paying the PBM a rebate and the providers are getting the 340B pricing on the same drug. That's part of the reason why we've seen discriminatory contracts. We've seen PBMs trying to underpay 340B providers, et cetera, et cetera. So there's a ton of stuff in the background that I could go into as it relates to this. But the main point that I want to point out is this is, in the manufacturers' minds and some of the folks that I've spoken to, a $10 billion issue where manufacturers are paying, or reportedly paying $10 billion in duplicate discounts related to this. So this national clearinghouse portion of the bill is of extreme importance to the manufacturers. I'm hearing that this is kind of like a huge win for them, that this is the most important piece in this bill, even more than manufacturer restrictions, that if they are able to get this passed and put into law and operated, that they will be very, very happy with this. Although there's still talks that there's some talks of wanting to reduce the number of contract pharmacies or possibly put a cap on the number of contract pharmacies. But this comes with a lot of cons to it as well. This would require a world where entities are across the nation submitting prescription level data to this national clearinghouse, this third party company that will then report or work with the manufacturers to say which prescriptions got a 340B pricing and are not eligible for a rebate. So the amount of data sharing, I think, it raises huge concerns. Um, and also, what does that mean for Medicaid? I mean, there's a lot of states right now that handle Medicaid differently. There's a lot of entities right now that are reporting on Medicaid using a modifier. There's a lot of entities that are not considering Medicaid managed care claims as 340B eligible, for example. So what does this do for all of that? And that's yet to be determined. But as I understand it, this part of the bill is very, very critical for manufacturers, and is probably going to stay in, as part of the final bill that is ultimately put together. So there's very interesting conversations that I've had related to that in terms of what manufacturers are wanting for preventing duplicate discounts. So yeah, Justin, I don't think I shared that with you from a lunch that I had with this company that is part of that in Congress and working with folks in Congress. But I found that to be very interesting, that the commercial side is what they're actually worried about.
Yeah, my heart definitely bleeds for the $10 billion loss for the manufacturers. I'll cry for them tonight when I'm laying down. But yes,
Send me a video.
that's good information.
Send me a video.
Yeah.
All right, so PBM discrimination practice. Again, this is huge for providers. This would be a big win. Providers have been tackling this at a state-by-state level. This bill actually has a $5,000 a day penalty for PBMs that underpay entity or engage in discriminatory practices. That could mean we're not going to contract with you, we're going to delay your contracts. That type of activity could be viewed as violating sort of the bill, and could come with a $5,000 penalty per day. So this is an area where comments are being asked. I think this is one that people understand very well, especially because there's been such a momentum at a state level of passing these bills, that this is one that is very important for 340B providers, and one that I recommend you comment on, especially if you own in-house pharmacies. This could be something that impacts you if you're an entity that owns in-house pharmacies and is expanding on in-house pharmacies, or are facing discriminatory contracts and things like that. This could be something that is affecting you, and I highly recommend that you comment on this. The other piece that I want to touch on is the user fees. This is not new. If you've been in 340B for a while, you would know that there have been multiple times where this has been floated. It never stays and never sticks. I don't know if this time it will, but there is a provision in the bill where there's a funding mechanism for additional program oversight, which will require 0.01% of the savings the CE receives. The calculation says it is the difference between WAC and 340B, which is very interesting, because that's a bigger number than it would be GPO to 340B, but it says WAC and 340B for additional program oversight. Again, I don't know what that means. I think there's a lot of oversight already. There's a whole section on oversight in this bill that is very interesting, of how much more can you audit, but it looks like that is some of the goals, I think, and some of the intention here with the user fees. All right, now let's talk about a quick pros and cons. What's the good and the bad of this bill? And again, this is just my opinion from being in this stuff, being in this space for a decade, from sort of understanding the provider side. I haven't been a 340B manager at a large dish hospital and also an FQAC. Um, the good thing that I think I want to highlight, and this is what I have seen people, sort of different articles, different webinars and stuff, is it undoes the manufacturer restrictions. It reverses the manufacturer restrictions. A report just came out that entities are facing an $8 billion loss due to manufacturer restrictions of savings. That's money being removed from the healthcare from healthcare providers because of these manufacturer restrictions. So that is a huge win, the most important win that is part of this bill. I personally like the 340B Patients Act a lot better. It is a 9-page piece of legislation. It is only focused on, for the most part, manufacturer restrictions. It is a cleaner bill. It's been introduced and all that good stuff. I personally would prefer that bill over everything else that's in this bill, but I think this is good. Number two, it solidifies in statute Congress' intent for the program. I think that's good that there's no discussion about the intent of the 340B program. It is to help providers maintain and expand healthcare services, period. Right? I think we know that. Um, a lot of providers saying the bill is balanced. There's a lot of good in the bill. There's some stuff that's concerning in the bill. There's the senators are asking for additional information, which is good. It's a good sign that they're still open to some flexibility and changing some things around. I'm torn on the National Clearinghouse. I don't know if that could be good for some entities that are foregoing Medicaid managed care savings today. I don't know. It could be. If entities get to claim the 340B discount first, right? If it's the opposite and entities have to give up the 340B discount for the state to get the rebates, then I think it's bad, right? So I don't know what that's going to look like operationally, but there could be good for covered entities as it relates to the National Clearinghouse. Again, it's going to come with, you have to submit, files now. You're going to have to submit prescription level data. There's concerns whether is this going to have the limits that the ESP portal has today, where you're going to be limited to a certain number of days, right? There are so many questions here that I don't have the answer to, and I'm just trying to provide the facts that I don't know which way is going to go. If it goes the way of the providers being able to claim the 340B discount, then it's a good. Um, all right. Some of the things I don't like about the bill. The patient definition pending is worrisome. I think Justin's right. If at the end of the day we get the 1996 patient definition, I think people will be happy. Okay. If we get the Genesis definition, I think we'll be very happy. But the 1996 patient definition, I think, is it's sort of the starting point, and where I hope and pray that this ends in that section of the bill. The bill does have significant administrative burdens that had not existed before for 340B entities. So the 340B ESP sort of laid the foundation for that. Now this is taking it up a notch to a whole nother level. So that's concerning. There's some reporting requirements that could have data sharing concerns. What kind of data is going to need to be shared with this national clearinghouse? And those sorts of things that were a big issue at the beginning of the 340B ESP reporting. So that's concerning, and I don't think that's too good. The additional funding, the user fee, I think that's obvious, right? That how to calculate that, how to pay for that. What if an entity doesn't pay? I mean, there's just so many questions related to that are just worrisome. The additional funding allocated to more audit and oversight is, what does that mean? Like, what does that look like? Does this mean that an entity that's been audited every year is going to be audited more than once a year? There was some language in there about covered entities and contract pharmacy audits. Like, what does that mean? Is it that there's going to be a different type of audit for the contract pharmacies than for the covered entities? Like, there's just a lot of things about additional oversight, and additional reporting and things like that I think are not very clear. The contract review process. So Justin, this was really interesting because you work in sales, right? But this is really interesting. And the bill seems to indicate that there will be an annual registration. And not only that, but it seems to indicate that there needs to be the establishment of a contract review process. So some sort of process where a contract between a covered entity and a contract pharmacy is submitted to the OPA for review. Which sounds pretty crazy to me.
Yeah.
Oh, because submitting anything to the government for review is going to
And then the sheer number of
right.
contracts, and especially if they're looking at them annually, there's just the burden is there's no way they'd have
Yeah.
to do a random selection, and I guess maybe looking for dispense fee abuse or something like that, or it just
So
that's that's something that would never be able to be
yeah.
operationalized, I don't think.
Yeah, I think so. I think that's probably it, where there is some worry about dispensing fees or something like that. But I just can't even fathom a world where like TPAs and entities have to send a 340B provider and contract pharmacy agreement to HRSA or to the Office of Pharmacy Affairs for review, then get it back, then register the contract pharmacy. Like that will be insane. That would be crazy. So I hope that doesn't happen. But anyways, that's something else that I read in the bill that was very, very interesting. Let's just say. Um, there's a lot of summaries around this bill. I actually read all 51 pages, so some of this stuff I'm pulling from actually reading the bill. There's a lot of summaries that won't touch into some of these things. So if this is surprising to you, I encourage you to go and read the bill. If it's not the most exciting thing to do, but if you want to do it, you're more than welcome to do it. It's out there online. All right. So why don't we wrap this up? Let's wrap this up and let's talk about what's a call to action. So again, consensus is that the bill strikes a good balance. I think that for 340B providers, the fact that both this bill and the 340 Patients Act are very clear on the reversal of manufacturer restrictions is good, and I'm very excited about that. That I'm glad that that is the consensus, at least from folks in the government and Congress that understand the good that 340B does for the healthcare system, for patients, for communities, et cetera. So I think from that standpoint, then I guess we could say, yes, it strikes a good balance. Stakeholders highly encourage you and recommend you to comment, especially on the patient definition. But comments, they're due April 1st, 2024. Here's the website where you can submit your comment to the Senate committee, the gang of six, the group of six that are working on this bill. Please do that. Highly encourage you to do that. Very, very important. To ensure that they are hearing your voices and the impact that you're having on the 340B program in your community and helping patients. All right. So that's it, Justin. That's all I got. It looks like we have a ton of Q&A. Please don't leave. I see some of you guys are dropping off. Don't drop off. The Q&As are really, really good. Always ton of information there. Good insight. Feel free to reach out to us if you have any questions. You can email us at info@thepharmaforce.com. Justin will get it. Someone on our team will get it. And we'll communicate with you. Follow us on our socials. We're thinking about maybe doing these webinars a little bit more frequently. Maybe even possibly doing a podcast. So there's a lot of things that we have going on, and sort of keeping this dialogue and this information sharing with entities and providers and pharmacies and other professionals in the space. So Justin, I'll turn it back to you.
And Anthony, I'm gonna flip it back to you. I gotta jump to
Oh, that's right.
a demo.
All right,
So
get out of here.
I will not take your advice. I will not stay. Thank you,
All right.
everyone. See you next month.